And now I am pleased to introduce Dr. Stephen Bede, who has served as the medical advisor for the Nova Scotia Organ and Tissue Donation Program since its inception in 2006. Dr. Bede is the chair of the National Deceased Donor Advisory Committee, as well as a member of the Organ Donation and Transplantation Export Advisory Committee through Canadian Blood Services. Finally, Dr. Bede is a clinician at heart and has completed postgraduate training focused on adult critical care medicine, as well as thoracic and cardiovascular anesthesia. Dr. Bede will be speaking against the adoption of presumed consent legislation. Dr. Bede?
Thank you very much for the invitation. Fly across the country to talk to a bunch of people who are absolutely committed to donation and talk about a topic that sounds like it makes perfect sense, except argue against it. Sure, I'll do that. I think it was to escape our horrendous winter, because this is a lot nicer here. Now, I have a lot of stuff to get through. I'm going to try and make my argument and make it as data-based as I could, and I'm going to fly through a bunch of stuff. But I think I'd like to follow this up by saying that I think, whether you realize it or not, you've already made my argument in the first section of this, and I'll point out why. So, where are we going to go? First of all, no financial conflict of interest. I've worked a lot with CBS. I want to acknowledge some colleagues from around the world who I've worked with, who've provided some of the slides. What I want to talk about is the Canadian perspective on this topic to some extent, and then outline what really is presumed consent, where is it used, does it work, and then a little bit about what's going on in Nova Scotia. And I'll follow this up with my opinion for whatever that's worth. So what do we know? Well, this room is certainly aware of the fact that we need more donors. There's no quarrel with that. But we want to do this ethically. There's no question that improving donation is the right objective, but we need to do it the right way. Certainly the China experience using political prisoners, not acceptable. Transplant tourism, if you're wealthy enough, you can buy an organ from some poor peasant in a different part of the world, not acceptable. But we do and must do better. We're a wealthy, advanced nation with one of the best healthcare systems in the world. We've got a population that are overwhelmingly supporting donation when you survey them, and our system performance is mediocre at best. Now, we have improved in the last 5 to 10 years slightly, but our donor rate is roughly 15 donors per million population. To put that in perspective, BC is now around 14 and had been at 8 or 9 donors per million a few years ago. The best performing countries in the world are in the high 30s. So we are not close to the best performing countries. There's work that needs to be done. We know the arguments, so let's just assume everybody consents, unless they don't. Let's look at that in a bit more detail. What is presumed consent? Obviously, the de facto policy is you're a donor unless you've opted out, more or less, in a presumed consent world. But opting out can take 2 different forms depending on the country or jurisdiction you're talking about. The hard opt-out, basically, we're taking your organs once you've died if it's appropriate, period, full stop. We're not talking to your family. There's very few countries in the world do that. The vast majority that have a presumed consent approach are still consulting the family. And if the family object, there's an opportunity to change the process, and I'll show you data on that. What do the public think about this? It's important. The public in Canada are not the public in this room. We are a different segment by virtue of the fact that you've shown up here today. You are a different slice of the Canadian population at large. Now, this is not scientific, the Globe and Mail, but this showed about 80% of the population saying no to presumed consent. Obviously a biased selection, but this is not so biased. A recent survey done by the Canadian Blood Services, this is focused on healthcare professionals, doctors and nurses mostly, and the data here shows that basically about 55% of healthcare professionals support legislative change to presumed consent, but that's just a little bit over 50. and recently done public surveys by CBS in light of some of the issues occurring in my province, showed that the public at large are about 55% as well. But there's been a significant may overstate it, but there's been a real shift in that over the last 10 years. We used to be a little bit under 50 or thereabouts, but we're increasing, so we're pushing our way towards 60% consent towards support for presumed consent when the public are surveyed. In the UK, Wales have just adopted a presumed consent, and their public survey data shows that roughly 60% of their population were on board with this strategy. So, what's happening around the world? This is the data. If you look at it, there in green you see countries that have explicit consent. That is like Canada. You have to get permission from the family. In the blue countries, we have presumed consent. That's not going to show up very well, obviously, but essentially what that shows is that even in explicit consent countries where you have to ask the family, there are a couple of countries that accept first-person consent. So in those countries, if the person had registered as a donor, then that counts as their consent, and they will go ahead with donation whether the family agree or not. But there's only a couple of countries that are willing to override the family opinion. This is in explicit consent. Almost everywhere, the family's issues in the midst of this tragedy are the priority. And if you take a look at what happens in presumed consent countries, the same trend is seen. And that is, even when you have presumed consent, in just about every country, they are still talking to families and indeed getting permission from families to proceed. And if the family in that setting said no, it would not proceed. There are a few countries that go ahead anyway, but almost all presumed consent countries take that soft opt-out option. So family right to veto is almost universal, but not completely. So, an important question with all of this, does it actually work? Is it a strategy that increases donation? And I'll show you the data on that. This brief graph would suggest, if you look at the left-hand side, countries with presumed consent in general have higher donation rates. Now, I could have thrown Bulgaria at the far end of it, which is also presumed consent and has a donor rate about where Japan is. So it's not universal, but there seems to be a trend that says when you have consent, presumed consent, your donation rate is higher. And I'll follow up on some more specifics. This is Croatia, a country that not so many years ago had a horrendous donation rate, about 4 donors per million. And now you can see, oh, sorry, this is Belgium. I'm getting to Croatia. Belgium has increased their donation dramatically, as you can see. Their culture is a little bit different. They started off with a culture medically that said, before presumed consent came in, they said, if we want to do an autopsy, we're just going to do it. We don't talk to the family. We think it's the right thing to do. Well, if that's your norm, then switching to presumed consent wouldn't be particularly offensive to most of that community. In any case, they brought this in, and you can see dramatic increases in their donation rate and their transplantation rate, and now they have very respectable numbers that are pushing 30 per million. If you look at Croatia, this is a dramatic success story. Terrible rates, 2.7 donors per million, but with investment over a period of several years, they actually now have the highest donor rate in the world. But if you look at, this is a recent publication that reviewed what they did, presumed consent was part of the change. But if you focus on what's in the top red, you're focusing on what they consider to be the real reason that they improved their performance. And that was investment. And there's a theme that you should take away from this, which is important to BC as a whole, and that is the investment in the critical care community. That theme comes up across the world. In almost every country with real success, you have critical care investment to support donation. And indeed, that was a key part of Croatia. Presumed consent was part of their bundle, but it was other things. Spain is always looked at as the most successful country in the world. And what you can see, again, from a publication that's now a little bit dated, But although they acknowledge presumed consent is an integral part of their system, if you will, they also will tell you that it really isn't the reason that their system is as good as it is. And they do talk to families. They have the soft opt-out option, even though they have presumed consent. So, a scientific academic publication that looked at a collection of system performance across a bunch of programs with presumed consent. And as you can see, the general conclusion of this was that there's roughly a 20 to 30% increase in donation in countries that have presumed consent. Another publication, looking at a slightly different metric, their conclusion about the same. When you have presumed consent as part of your donation system, your donation rate is up. So, does it work? Well, it appears to be related. True, unrelated, not entirely sure, but it certainly seems to be related to high-performing systems. The key here, though, is, was it the presumed consent part of that system that was the key issue? And that's a difficult thing to tease out. But let's just presume that the increased system performance in these countries that adopted it was just because their consent rate went up. It went from, 50% before to effectively 100% because everybody was presumed, for argument's sake. So we have several situations. One of them is the family who don't support donation, but in the new model, they end up donating. Well, that's not good. We've sort of twisted their arm, even if donation went up. What about the family who had reservations? They're sort of on the no side, but they don't feel strongly about it. But in a presumed consent world, they go with the flow, and donation goes up. That may or may not be good. The third thing I've highlighted here is what I think happens most of the time. I'm an intensive care doctor. I'm at the bedside. I've been there for years. I've dealt with, I don't even know how many families in the midst of this, and this is common. Families are going through the worst thing you can imagine. They're not thinking straight, they're exhausted, and having a presumed consent option removes them the burden of having to make a choice. If you have presumed consent, that family donates, and they wanted to anyway. What happens if it's not really related to your consent going up, but what you do when you invoke presumed consent is you send a message from the government, from the Department of Health, from the medical community, from whoever, that says donation's really important. You got to get that message. And one of the ways we're saying it's important is we're making a law. Well, if you didn't specifically increase donation by the consent going up, maybe that has some overflow benefits because that message disseminates to the broader community. The public see this clearly as an important issue. They get informed. They're more likely to be on board. The health community, which I can tell you in the broad sense, the health community does not know about donation and transplantation. The physicians and the nurses in your communities in general do not know about donation. They're uninformed or misinformed, and they're the resource for their local community. But perhaps they get more informed in a new world. I'm not sure. So I've given you a little bit of information around presumed consent. Let's talk about where we sit in Nova Scotia. We're small. We really are. But we've had, over the last 5 years, about 21 donors per million. Comparing that, BC was at about 8 to 9. Now you've done great. You're up to 14. We're at about 21. We have a DCD program. You know, we've been kicking along, doing okay. I don't see our success. I see the things we have to do better. But this is not a bad set of numbers unless you're the person still waiting for a transplant. I was blindsided by this. It's a national news story, so it may be that you in BC knew about this before I did. The Minister of Health, newly elected, absolutely well-meaning, lets the media know that Nova Scotia's thinking about presumed consent, and I didn't know a thing about it. That's not the right way to find out about it, but it makes it a high-profile item all of a sudden. Imagine if I had done that to the health minister. it wouldn't have gone over so well. So what did that do? Well, it brought people out of the woodworks. And this is an example of what happened. And these are people that are working a few hundred yards down the road from me, but have never, ever picked up the phone and said, you know, I've never been at a bedside. I'd like to talk to you about what actually happens. They feel entitled to a set of opinions on this topic, but to my knowledge, they know nothing about what actually has happened at the bedside except second, third, or fourth hand. But a message that was clearly disseminated when the minister said, let's think about presumed consent was, Big Brother, you know, the paternalism of government. This was one publication. There was also an editorial that was published, a similar situation. This individual has been fairly high profile media-wise with some very strong opinions, and an editorial was precipitated by the minister's remarks. And I would point out some of the things, and these are quotes from her editorial. I sort of agree with the first part. There may be issues around obtaining consent, fair enough, and perhaps the immigrant group or people with disabilities may not really understand how you would opt out if we went to a presumed system, so maybe they're disadvantaged. I can't quarrel with her on that. But the other things she included in her editorial are absolutely wrong, and some of them are just offensively wrong. I know that. I work in this field. I've spent a lot of years dealing with these families and these patients. But Joe Q Public doesn't, and most of the healthcare community don't, and they read this editorial, and she is given credibility that, frankly, she does not deserve, and that's a problem with this. So my conclusion is that presumed consent, on balance, a soft no. But what are we doing? We have a new Human Organ Tissue Donation Act in Nova Scotia that's going to have required referral and first-person consent that's binding, and we've got some other system things we're working on. And why are we working on them instead of presumed consent? This is the data that makes my case. Our consent rates are as good as anyone in the world in Nova Scotia. I don't know what the BC consent rates are. But we have 80+% chance of having consent if you're a potential donor in our ICU. And this slide is very important. These are made up numbers, but they're pretty accurate in terms of how the donation process occurs. And if you look at it, it highlights where the donation process might or might not be improved. And if you talk about presumed consent, we've got a donation consent rate that's in the 80% range. If we went to presumed consent and it went to 100, in this little schematic, we increased donation by 5. But the real problem from a system point of view is not the consent. It's in the referral of the potential donor, the identification of the potential donor. And as I said, you made my case for me when you presented the BC data. If you look at 25 donors per year in BC, up to 70 donors per year, a 300% increase almost. I can tell you that at least some of what happened in BC over that period of time was a real investment in critical care, which I am certain resulted in increased identification, referral, and support of the potential donor. That's almost a 300% increase in your donor rate, and it had nothing to do with presumed consent. But it did have to do with investment in areas that have worked in other parts of the world. So, our real problem when we talk about increasing donation performance is not related to our consent rate in Nova Scotia. In some other areas it may be, but I think the gain is still not as significant as it could be. If you had $1,000 to improve the healthcare system and you thought you could do it with $1,000, maybe you would do everything. But then somebody says, you're only getting 100, you better be really careful about how you spend your resource. Well, that's our reality, and I'm sure that's BC's reality. Well, if we have to be very strategic, look at this diagram and tell me where you think the best place is. Identification and referral give us more bang for our buck from presumed consent. So it's the wrong target, especially in light of what might precipitate You saw some of the strong opinion in that editorial. These are some of the issues that were raised when the British Isles were considering this. And one of the key things is that there is a perception amongst the healthcare community and the public at large that this trust-based altruistic system could be changed somehow if we go to presumed consent. And that is a big deal. And this is an example of that. Germany has quite a high-performing system, or they did. As you can see from this diagram, they were doing quite well, and then what the heck happened in 2011? How do you go from 1,300 donors down to 850 in 1 to 2 years? Well, I'll tell you what happens. Some of the physicians in the system game the system for good reasons. My patient in my town in front of me is waiting too long. I'm going to say that they're sicker than they really are, which bumps them higher on the transplant list and makes them more likely to get an organ. And I'm fighting for my patient. And that's what they did. The problem is it meant the public's trust in that system was completely compromised. They thought it was sort of a fair playing field and everybody knew what the rules were. And you can see in 1 year, trust in the system changes and donation plummets by 40%. The trust that we have is sacred. So what do we do in the future? I think Nova Scotia is a reasonable place to consider presumed consent. But if we're going to do it, I think we have to do it correctly. So how would I do that? And get out in front. We need to control the message. I think this is something to consider. We know the population support donation. Most of the people in our province, your registry is 19%. In Nova Scotia, we're at 55%. We know people want their wishes respected when they die. Donation is a good thing at a bad time. That's the message people need to hear, not the message that my colleagues from down the road were espousing, which is scary and wrong. We need to make sure that if they object, that we support them. So first, we educate. The political leadership have influence, but they don't know what they're talking about on this. We need to get them up to speed. Family doctors have influence, but they need to get up to speed. Our emergency colleagues and our ICU colleagues need to as well. That's where we target it. We have to respect those who disagree. Any family that says yes or no is treated the same way. A soft-out, opt-out philosophy, obviously. And very importantly, if we're bringing this on board, there has to be a well-defined, easy-to-use, culturally sensitive mechanism to opt out. In Nova Scotia, about 30% of our population are illiterate. People don't volunteer that they couldn't read the pamphlet you handed them. But we need to be aware of that. So that opt-out registry is an important part of our solution. Plan for the surge. We don't start this, have great success, and then find we can't support it. And then we hold on.